Hello, everyone. My name is Kaile Hilliard. I'm a master's social worker, licensed clinical social worker in the state of Colorado, and I am with Granite Peak Healthcare Solutions. Today, I'm going to be talking about substance use disorder and the federal regulations for long-term care. We will be discussing substance use disorders regulatory overview and the documentation requirements, co-occurring disorders, and signs and symptoms of substance use disorder. Important definitions. Substance use disorder is defined as a recurrent use of alcohol and/or drugs that causes clinically and functionally significant impairment, such as health problems, disability, and failure to meet major responsibilities at work, school, or home. Medication-assisted treatment, MAT, is the use of medications in combination with counseling and behavioral therapies to provide a whole patient approach to the treatment of substance use disorders. Opioid use disorder is a problematic pattern of opioid use leading to clinically significant impairment or distress. Additional criteria used to assess and diagnose OUD can be found in the DSM-5. There are several tags that mention substance use disorder. The first one that we're going to discuss is a 557, respect and dignity. And this is where it discusses that it's okay to ask residents who appear to be exhibiting signs and symptoms of illegal substance use if they have used or possess illegal substances. Facilities cannot search a resident without permission or act as an arm of the law, but they can refer to law enforcement when there is suspicion. Facilities will need to provide increased monitoring and supervision if they suspect a resident is using or possessing illegal substances. F563 is the tag that covers visitation. Visitation policies can include denying access or providing supervised visitation to individuals who have a history of bringing illegal substances into the facility, which places residents' health and safety at risk. F689 is the biggest tag, which covers most of the substance use disorder information. It specifically hits on elopement risk and substance use disorder, and then notes that residents with a history of substance use disorder should be assessed for elopement risks, and care plan interventions should be implemented to ensure the safety of all residents. Care planning interventions should provide appropriate diversions for residents and encouraging residents to seek out facility staff to discuss their plan of care, including discharge planning, if appropriate. Any resident who has a history of substance use disorder that is documented in a hospital documentation or in a psychosocial history assessment, those are the ones that you're going to want to ensure that there is a corresponding elopement risk assessment and that you have a corresponding care plan that addresses the substance use history. A resident with decision-making capacity leaving the facility intentionally is not considered an elopement unless the facility is unaware of the resident's departure and/or whereabouts. A resident who leaves the facility prior to his or her planned discharge, but with facility knowledge of the departure and despite facility efforts to explain the risks of leaving, would be considered leaving against medical advice. Documentation in the medical record should show that facility staff attempted to provide other options to the resident and inform the resident of potential risks of leaving AMA. Documentation should also identify the time the facility became aware of the resident leaving the facility. It also covers ongoing substance use during the stay at the nursing facility. Residents with substance use disorder may try to continue using substances during their stay in a nursing home. Facility staff should assess the resident for the risk for substance use in the facility. If your facility is aware of a resident who has been actively seeking out substance use, it is imperative that an assessment is completed, documentation is noted, and a care plan is updated. Efforts to prevent substance use may include providing substance use treatment services, such as behavioral health services, medication-assisted treatment, Alcoholic or Narcotics Anonymous meetings, working with resident or the family on their goals, and can also include increased monitoring and supervision. If there is a history of substance use disorder, the resident's comprehensive care plan should contain interventions to prevent substance use in the facility and for when substance use is suspected or identified. Facility staff should implement care plan interventions, which should include increased monitoring and supervision of the resident, increased supervision of visitors, if applicable, Notification of the resident's physician or non-physician practitioner. Pain management F697 also mentions substance use disorders, particularly around opioid use and the use of naloxone. For opioid use, if there is a history of substance use disorder, the lowest possible effective dosage should be prescribed for the shortest amount of time possible. The resident should be monitored for effectiveness and any adverse effects. When treating pain in a resident with an addiction history or opioid use disorder, strategies must be used to relieve pain while also considering the opioid use disorder or addiction history. These strategies may include medication-assisted treatment or non-opioid pain medications and non-pharmacological approaches when appropriate. Naloxone. The Substance Abuse and Mental Health Administration states opioid overdose deaths can be prevented by administering naloxone. The United States Surgeon General has recommended that naloxone be kept on hand where there is a risk for an opioid overdose. Facilities should have a written policy to address opioid overdoses. F699, Trauma Informed Care, discusses that residents with a history of trauma may have diagnoses such as anxiety, depression, or may have substance abuse issues such as alcoholism, and or may abuse prescription medications or street drugs. Trauma-specific interventions should recognize the interrelation between trauma and symptoms of trauma, such as substance abuse, eating disorders, depression, and anxiety. Social services needs to assess for trauma and substance use disorder and recognize potential link between the two. Care plan and document accordingly. F740, Behavioral Health Services, discusses that for residents with an assessed history of mental disorder or substance use disorder, the care plan must address the individualized needs the resident may have related to the mental disorder or substance use disorder. This could include behavioral contracts, access to individual group counseling, or medication-assisted treatment. Steps the facility may take if substance use is suspected may include increased monitoring and supervision in the facility to maintain the health and safety of the residents suspected of the substance use, as well as all residents. Restricted or supervised visitation if the resident's visitors are deemed to be a danger to the resident, others, or staff. Voluntary drug testing if there are concerns that suspected drug use could adversely affect the resident's condition. The important key word here is voluntary. Residents can refuse, and it is within their right to refuse drug testing. Voluntary inspections can also be conducted if there's a reasonable suspicion of possession of illegal drugs, weapons, or other unauthorized items which could endanger the resident or others. Again, the key word is voluntary. The facility cannot bring in a drug dog and have a drug dog sniff out potential substance uses. This is a violation of their privacy. Residents living with mental health and substance use disorders may require different activities other than other nursing home residents. 740 Behavioral Health Services also discusses behavior contracts, and some facilities may use these as part of the individualized care plan. It is important to ensure that any use of behavior contract does not be construed as meeting the definition of abuse, which is the willful infliction of punishment and or the deprivation of goods and services. The contract cannot conflict with resident rights or other requirements of participation. Generally, utilizing a reward system, without calling it a reward system, because you also don't want to treat them as children, but a motivational factor is important, and that has to be something that the resident is a part of developing the agreement for. It cannot just be the staff decide and not include the resident or a mental health provider if they're appropriate, potentially the ombudsman and or family responsible party members. Behavioral contracts should be used for residents who have the capacity to understand them. Putting a behavioral contract in place for somebody who has advanced dementia and cannot reasonably be expected to follow through or remember elements of the behavioral contract should not be having behavioral contracts used for them. Behavioral contracts should be developed with the input from the resident, mental health provider, IDT, and ombudsman if appropriate. Behavior contracts should identify 1 to 2 SMART goals and identify a positive reinforcer. SMART goals mean that they are specific, they're measurable, they're achievable, they're relevant, and they're time-bound. Behavior contracts should be consistently applied by all staff for success. This means that all staff will need to understand the parameters of the behavior contract and how to implement it. Behavior contracts should be reviewed regularly for goal evaluation and adjusted if needed. And this may mean that it's evaluated sooner than a quarter. 741 Staff Competencies discusses that the facility must identify the skills and competencies needed by staff to work effectively with residents, both with and without mental disorders, psychosocial disorders, substance use disorders, a history of trauma, and/or PTSD. Staff need to be knowledgeable about implementing non-pharmacological interventions. The skills and competencies needed to care for residents should be identified through the facility assessment. Staff should be able to identify the signs and symptoms of substance use in a resident with SUD. They should be able to provide care in accordance with the individualized care plan that meets the needs of residents with mental disorders, substance use disorders, a history of past trauma, and other behavioral health needs. It is important that all staff are aware of what the interventions are. So ensuring that behavioral interventions are appropriately carried over for CNAs, frontline staff to be able to readily and easily access is important. 741 discusses non-pharm interventions to address substance use disorder or mental health needs. This could mean individualizing sleep and dining routines, adjusting the environment to be more individually preferred and home-like, assigning staff to optimize familiarity and consistency with the resident and their needs, supporting the resident through meaningful activities that match his or her individual abilities, interests, goals, and needs based on their comprehensive assessment, and that may be reminiscent of lifelong work or activity patterns. Assisting the resident outdoors in the sunshine and fresh air, providing access to pets or animals for a resident who enjoys pets, assisting the resident to participate in activities that support their spiritual needs, assisting with the opportunity for meditation and associated physical activity, focusing the resident on activities that decrease stress and increase awareness of actual surroundings, such as familiar activities, offering verbal reassurance, especially in terms of keeping the resident safe, and acknowledging that the resident's experience is real to him or her. Utilizing techniques such as music, art, electronics, computer technology systems, massage, essential oils, and reminiscing. Assisting residents with SUD to access counseling, for example, individual or group counseling services, 12-step programs, and support groups to the fullest degree possible. Many of these can be done online, and so then you don't have to plan for transporting a resident to and from. Some facilities even volunteer to host 12-step programs and Alcoholics Anonymous, Narcotics Anonymous. Assisting residents with access to therapies such as psychotherapy, behavior modification, cognitive behavioral therapy, and real problem-solving therapy. And providing support with skills related to verbal de-escalation, coping skills, and stress management. Let's talk about co-occurring disorders that often occur with substance use disorder. People with mental illnesses are more likely to experience a substance use disorder as well. According to SAMHSA, approximately 9.2 million adults in the United States have a co-occurring disorder. Some of the most common mental disorders seen in medical assisted treatment include anxiety and mood disorders, schizophrenia, bipolar, major depressive disorder, conduct disorders, post-traumatic stress disorder, and attention deficit hyperactivity disorder. Patients being treated for mental disorders often misuse the following types of substances: alcohol, tobacco, opioids, stimulants, marijuana, hallucinogens, and prescription drugs. Let's discuss signs of addiction and drug and alcohol abuse. Behavioral signs of addiction can include, and none of these lists are all-inclusive, obsessive thoughts and reactions, disregard of harm caused, loss of control, denial of addiction or hiding drug use. Physical signs of addiction can include enlarged or small pupils, sudden weight loss or gain, bloodshot eyes, insomnia, unusual body odors, poor physical coordination, looking unkempt, and potentially slurred speech. Psychological signs of addiction can include anxiousness, inattentiveness, lack of motivation, irritability or angry outbursts, changes in personality or attitude, emotional and mental withdrawing from people, sudden mood swings, unexplained paranoia. This is not an all-inclusive list. Typical signs of overdose include drowsiness or trouble walking or waking, agitation, aggression or violent behavior, difficulty breathing, nausea and vomiting, hallucinations, delusions, loss of consciousness. Typical signs of withdrawal can include shakiness, trembling, and jumpiness, loss of appetite, nausea and vomiting, depression, insomnia and fatigue, headache and fever, confusion and hallucinations or seizures. Going into specific drug categories, typical signs of heroin abuse include constricted pupils for 4 to 5 hours, disorientation, shallow breathing, unkempt, dirty appearance, track marks on arms or other body parts, weight loss, stomach and/or muscle cramps or diarrhea, and tremors. Heroin is white in its pure form, but other substances are often cut into it and turn it rose gray, brown, or black. Typical signs of cocaine abuse can include increased energy, restlessness, paranoia, elevated mood, anxiety, feeling invincible, excited speech, dilated pupils. Cocaine is best known in its white form, powder form. Most often, this drug is snorted, smoked, or injected. As cocaine is a stimulant, one of the hallmarks is that its main effect wears off around 30 minutes to 2 hours after the last use. Signs of alcohol abuse can include blackouts, legal troubling drinking patterns, panic regarding access to alcohol. Some common signs and symptoms of marijuana abuse can include bloodshot eyes, increased appetite, lack of motivation, weight gain, nervous or paranoid behavior, impaired coordination, slowed reaction time, dry mouth, memory impairment, anxiety, impaired judgment, distorted perception, relaxed state or sleepiness, feeling high or euphoric. Along signs of hallucinogenic use, reflect increased heart rate, nausea, intensified feelings and sensory experiences, such as seeing brighter colors, changes in a sense of time, for example, the feeling that time is passing by slowly. Classic hallucinogens can cause users to see images, hear sounds, and feel sensations that seem real but do not exist. The effect generally begins within 20 to 90 minutes and can last as long as 12 hours in some cases. LSD, such as LSD, or as short as 15 minutes in others, such as synthetic DMT. Hallucinogenic users refer to the experience brought on by these drugs as trips. The experience is unpleasant. Users sometimes call it a bad trip. Signs of hallucinogenic use or abuse. Some short-term effects of hallucinogenics can include increased blood pressure, breathing rate or body temperature, loss of appetite, dry mouth, sleep problems, spiritual experiences, feeling of relaxation, uncoordinated movements, excessive sweating, panic, paranoia, psychosis, or bizarre behaviors. There is a possibility that users could experience long-term effects because they have been associated with the use of classic hallucinogens, although these side effects are generally rare. Persistent psychosis is a series of continuing mental problems, including visual disturbances, disorganized thinking, paranoia, or mood changes, or hallucinogen persisting perception disorder. Reoccurrences of certain drug experiences, such as hallucinations or other visual disturbances. These flashbacks often happen without warning and may occur within a few days or more than a year after the drug use. These symptoms are sometimes mistaken for other disorders such as a stroke or a brain tumor. Both conditions are seen more often in people who have a history of mental illness, but they can happen to anyone, even after using the hallucinogens one time. Signs of benzodiazepine abuse. Benzodiazepines are prescription medication used to treat anxiety, insomnia, seizures, alcohol withdrawal, and other conditions. Many well-known brands of benzodiazepines include Xanax, diazepam, Valium, and Klonopin. Signs of benzodiazepine abuse can include impaired coordination, dizziness, grogginess or drowsiness, trembling, depression, vision problems, confusion, or headache. Depressants have some characteristic physical side effects. As benzodiazepines are included in this category and have been discussed above, some other physical signs of depressant drug use include poor judgment, unsteady walking, and rapid involuntary eye movements. Signs of other prescription drug use. There's three main categories of prescription medications: depressants, stimulants, and pain relievers. So for stimulants, that includes amphetamines and methylphenidate, such as Ritalin, and they are most commonly abused drugs in this category. In addition to the behavioral and psychological signs of addiction that we've already talked about, physical signs of prescription stimulant abuse can include insomnia, agitation, irritability, impulsive behavior, irregular heartbeat, restlessness, high blood pressure, and weight loss. For pain relievers, these drugs are usually opioids, synthetic or partially synthetic drug that resembles opium in its compound structure. Common pharmaceutical painkillers of abuse include Opana, OxyContin, Percocet, and Vicodin. Drowsiness, inability to concentrate, drug-seeking behavior, an unhealthy appearance, and being secretive are often signs of pain-relieving drug use. Thank you for joining me today in talking about substance use disorder, the regulations for long-term care.